Hello everyone and welcome to RadChat Live. So we're at the annual meeting of the Surface Guided Radiation Therapy hosted by Vision RT. Got a new guest here, Rayk. Would you like to introduce yourself please?
Yes, thank you. Thank you for being here. I'm Rayk Nachtigall from Hamburg in Germany. I'm a medical physicist and I'm working now for 5 years in this field. Before this I was at the university doing completely different stuff. It's definitely a very rewarding profession.
What do you think drew you into oncology?
Actually, it was an interest during my time at the university. So there are different fields of physics I was interested in, and biophysics was one of them. The other things have been astrophysics and particle physics. This was what I was doing back in the university. And then there was just the idea, okay, they were interested in this field and let's pursue a profession in this.
Amazing.
When it comes to surface guided radiotherapy, I had the pleasure of watching your talk. You spoke very eloquently about trying to get the RTTs on board.
Yes.
Could you talk us through how you managed that process and the data you collected?
I have to admit we have a very innovative driven clinic. So all departments are on board if there's something new and something new to experience, and everyone is just looking at the new machines or the surface guidance in this case, and thinking about what can we do, what is our benefit from this system, and so it was a no-brainer for everyone to just hop on board and go on the journey with this one.
How do you think you instill that? Because how do you motivate people to want to actually implement something new? Because we've definitely experienced it where sometimes there's challenges in getting people to be motivated to change practice.
It's first of all, it's just a mindset we have in our clinic, and the benefits. Just occasionally or on a regular basis, look at where you're standing and what you achieved until this point, and sum up the benefits you have with this one. And for me, it's great to just look into the data we have with the system, and just prove on a very unbiased way what we can achieve, what the actual motion in that case from the patients is, and prove our RTTs that what we are doing is sufficient enough for what we want to achieve.
Yeah.
You talked about the motion and kind of managing that as well. So when it comes to rotations or then the region of interest, has a lot changed since you've implemented surface guided radiotherapy?
Yes, and really a lot. So the whole process was speed up. So you have this kind of virtual surface you just put your patient into, and it has somehow a gaming feature. So when I was the first time trying this, it was like, okay, where to put the couch? What can I rotate on the phantom? And it was less than 20 seconds when I managed to really set up this one. We even made a challenge out of this. We'll just take a basket, placed it, took a capture, and someone had to come in and replace the position of this one. And so it has these gaming features, but this is one point. But the benefits are we're speeding up with the process of patient setup, and we have a lot more information about the patient itself. Before this, we just had laser marks or the crosses we drew on the patients, and these are at maximum 3 points you have for a whole patient to set this up. Now we have a surface with thousands of points and informations, and in real time we monitor them after this. We can analyze this, and this is where I can tell our RTTs we're doing well on this one.
So you mentioned kind of having that evidence base, collecting the data.
Yes.
Is that something you build into your implementation strategy?
Yes. So it's in general when you talk about statistics in healthcare or in medical terms, you usually end up with a cohort of maybe 1, 2, 3 patients. In that case, we can increase this because during a normal treatment of about 5 minutes, we end up with over 6,000 data points. So this is where I'm happy to have really a base for statistics.
A lot of data.
Yes, and this is the fun part, and this is the part where I can
Not
say.
sure everyone would agree that much data is the fun part.
For me. And this is definitely the point where we can go to the community and say we have evidence, we have statistics, real statistics, and with proven tools, and show everyone what we achieved and what they can achieve.
So do you use SGRT in your department for head and neck cancer patients?
Yes, we do. So not only head and neck, so we use it for every indication, every lesion, and even the benign hip radiations.
Right.
We do.
And for the head and neck patients, have you changed what masks you use? So obviously there's the 5-point mask, 3-point open face.
Yes, there was an evolution, so we started just having a look at the region of the thorax and the pelvis, and at some point we were just, okay, why restrict it to this one? Let's see what we can achieve if we have not only this rigid mask, what can we achieve when we see the face of the patient?
Yeah.
And we took our most skeptical RTT for this one. We just asked.
You do have one then.
We just had a look who's the most skeptical.
Right.
So,
Okay.
of course, there are second thoughts on this one.
Yeah.
It's definitely an approach you don't do every day.
Yeah.
So yes, it changed a lot in our clinic. And so the most skeptical one was in charge of taking the data, analyzing the COMBEAM data. I assist him with the data from the system, and in the end it was like, okay, can't argue against the benefits.
Yeah. And have you witnessed lots of benefits from a patient experience perspective?
This is kind of two-sided. So yes, unfortunately.
Okay.
So unfortunately for the patients that they had to come in another time. Usually you want to treat your patient just once, and then hopefully everything is fine. But yes, we have the situations where patients experience both the closed masks and the open ones, and they never want to go back to the closed ones.
Yeah.
The benefit is obvious. So you have more freedom. You have you don't have this kind of wall over your face or the blanket you put over. You can breathe freely, you can look around, so the patients are more relaxed on this one, and there's none I can recall that would prefer closed mask.
Are there any clinical indications where someone would have to have a closed mask?
Not a completely closed one. If they need a mouthpiece, we let this be covered by the mask, but no. Besides that, no. That's why we dove into the data and checked how much benefits we have and what difference it makes to have this. And the data showed that we have patient margins throughout the therapy below 1 millimeter from their setup point in the ISO center. So there is no indication to go back to the closed masks.
And for anyone out there who's maybe got SGRT, using it maybe for patients with breast cancer, what advice would you give them about kind of transitioning to treating patients with head and neck cancer?
That's a tough one.
What do you wish you'd have known?
In an ideal world.
In an ideal world, at some point you need the confidence to go this step.
Right.
And I know there are many people who are hesitant to go in this way, and I can understand this because it's really going out of your comfort zone with this one, and it's not really intuitive at the point where you say, okay, we reduced the rigid structure to the minimum.
Yeah.
But I just can't say, go for it. The benefits will prove you right on that path.
And with that transition, do you do imaging and use the surface guidance? So you're essentially always checking anyway that you're treating correctly?
Yes, so taking the cone beam CT will never be, so we never will abolish this. So
Yeah.
we'll never say the cone beam is obsolete.
Yeah.
So this is a golden standard, so we see the surface and the cone beam sees the inside. So there's no arguing about this one. But you can reduce the imaging with this one. So if you go to head and neck, for example, the bony structures are very close beneath the surface.
Yeah.
So yes, we definitely reduce our imaging in the other regions, where now I think we halved our imaging in total.
That's pretty amazing. If you think about it, for places that haven't even considered surface guided, hopefully that's the data that you're bringing through and that'll push other people maybe.
Sorry again.
I suppose it's more of a statement saying that it's nice to see, obviously you've collected so much data, you're going to be able to prove this does work, it is going to improve practice. And I suppose hopefully, like you said, people will start to take the first steps towards saying, yes, we can do this in the future.
Yes, that's why we're attending events like this, just to go out to the community and show them what we've done, show them how we've done, and being completely transparent in what we do, so that they can reproduce this and find errors in what we did.
Yeah.
So please come to us, discuss with us what we did wrong to improve it further. And also we try to have contributions to conferences, national and international ones, where we show our data and go into the discussions with even more colleagues. And I'm more thankful for a skeptical one to argue with him or her than someone who's on my side already.
Yeah.
We always like to end our episodes with top tips. There's one thing you could say to anyone about surface guided radiotherapy or winning people over, or not winning people over, whichever one. What would you say?
That really depends on the perspective you take. If you take the perspective on the treating side, so your departments, the RTTs and physicians there, you can speed up the process.
Yeah.
If you take the perspective from the patient, you have more information and you can be more relaxed with this one, because you aren't marked for life like the tattoos. You don't have this cover over your face anymore. So yes, there is a lot of freedom and comfort one.
Brilliant. Thanks so much for coming on.
Thank you very much.